Welcome to the series uncovering the latest 2025 American Thyroid Association management guidelines for patients with differentiated thyroid cancer. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces that you can actually remember. Today we are covering recommendations 51 through 56. These focus on risk assessment during follow-up, reoperations, alternative treatments, and the safe use of radioactive iodine. Let us begin. The first recommendation is about ongoing risk assessment. This means we do not only look at the original risk of the cancer coming back, we also pay attention to how the situation changes over time. By combining the initial risk estimate with new information gathered during follow-up, we can adjust care plans. This ongoing assessment helps determine what type of imaging is needed and when it should be performed. Next, we move to treatment when thyroid cancer recurs. If another surgery is being considered, several factors matter. We look at what type of surgery has already been done, the size of the new growth, its location, how quickly it is growing, and of course the patient's overall health and preferences. But surgery is not the only option. There are non-surgical approaches as well. One is ethanol ablation. Another is radiofrequency ablation. These options can be especially helpful for patients who face higher risks of complications with another surgery. The next recommendation focuses on radioactive iodine treatment for single lymph nodes in the neck. If a lymph node is affected and cannot be managed locally, or if it has already been treated once before, then another course of radioactive iodine may be considered. Moving forward, external beam radiation therapy is introduced. This uses modern, highly targeted techniques such as intensity-modulated radiation therapy or stereotactic radiation to precisely direct treatment. It may be used for recurrences that cannot be removed surgically, or when the cancer has spread into surrounding soft tissue. Now let us look at radioactive iodine dosing. Patients who may need more than 150 millicurie of radioactive iodine should first undergo dosimetry testing to ensure the safety of the treatment. When giving more than 150 millicurie of radioactive iodine, a dosimetry-guided approach, either lesional or maximum tolerated activity, may be considered in patients with locoregional or metastatic disease. To prepare patients with distant spread of disease for radioactive iodine therapy, either stimulation with recombinant TSH or levothyroxine withdrawal can be used. Pulmonary micrometastases can be treated with radioactive iodine therapy, and this may be repeated if the disease continues to take up radioactive iodine and shows clinical response. Radioactive iodine dosing for pulmonary micrometastases should either be empiric with a range of 100 to 200 millicurie or 100 to 150 millicurie for patients older than 70 years. Or it can be estimated by dosimetry to limit whole body retention to 80 millicurie at 48 hours, with 200 centigrade to the bone marrow. Radioactive iodine avid macronodular metastases can also be treated with radioactive iodine, and therapy can be repeated when clear clinical benefit is seen. Dosing in this setting may be empiric, with 100 to 200 millicurie or 100 to 150 millicurie for patients older than 70 years, or guided by whole-body dosimetry to limit retention to 80 millicurie at 48 hours with 200 centigrade to the bone marrow. So to recap today's key points, risk assessment is an ongoing process and should guide how we follow patients over time. Decisions about surgery for recurrent thyroid cancer depend on multiple factors, and alternatives like ethanol ablation or radiofrequency ablation may be considered. Radioactive iodine may be appropriate for certain lymph node recurrences. External beam radiation is an option when surgery cannot be performed. Radioactive iodine dosing must be handled with care, particularly in older adults and patients with kidney disease. And finally, thyroid cancer that spreads to the lungs may be treated with radioactive iodine depending on the size of the lesions and their response. That concludes recommendations 51 through 56. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, do not worry. I have prepared notes for you. Visit easyendoprep.com to sign up for the newsletter and have all the key pearls delivered straight to your inbox. Stay consistent, and together we will work through all 84 recommendations one bite at a time.